My name is Sarah Spier, and I am a survivor of the opioid crisis. 14 years ago, I found myself addicted to shooting heroin. Now, if you had told me that that would have been my life, I never would have believed you. Prior to my addiction, I actually had the privilege of working in film. I worked on Academy Award-winning productions called No Country for Old Men. I worked with A-list celebrities and movie stars, and I even had started an international nonprofit in Africa where I brought people from the United States back to Tanzania for intercultural development. We built a library, schools, books, you name it. That's what I've spent a lot of years working on. So I had this big, beautiful, full life, and then I met someone who I fell in love with. And an author once wrote that love is giving someone the ability to destroy you and trusting them not to. I was young, naive, and in love, a very dangerous combination. And he really introduced me into the world of hard drugs. It started with partying too much and taking some prescription pills. And I quickly realized when I took pills that parts of my past that had always haunted me began to quiet. I was bullied. I had witnessed somebody take their own life. And I had this overwhelming feeling of being alone because of some inner family personal stuff that had happened. And so when I found drugs, I really started to feel numb, and I liked that. I know what it feels like to have your brain be hijacked, particularly in one moment. He came home one night and decided that I should try shooting heroin. And it was the injection that dictated my future. It was a rush so bleak, yet euphoric. And from that moment, I was hooked. I could not spend one day without trying to get high. I would shoot drugs all day long. I was covered in track marks from my toes to my neck. And I lost everything I had ever owned. I lost my smile. I lost all morality, sense of purpose, hope. I was a ghost of the self that I once was. And then came a day when I decided that I could not take the misery and the pain that had become my life. And on that day, I actually tried to commit suicide. Now, few people can say that their mother brought them into this world twice, but I can. Really, my mom is the hero in my story. She had a horrible feeling the day I tried to commit suicide, and she actually showed up to the apartment that I was living in, and she found me unconscious and close to death. And she rushed me to the hospital where I went into a vegetable state, stroke-like coma. I was hooked to machines. I was in diapers. And my mom sat there and she held my hand the entire time, and she looked at me and kept saying, "Sarah, today is not the day you're gonna die. You're gonna live, we're gonna fight, and you are going to survive this." And that was 14 years ago. In the last 14 years of my recovery, I have been blessed beyond measure. I decided to do something with that second chance that I was given, and I enrolled in school where I studied international political science with a focus on socioeconomic development. And I really became an international drug treatment researcher. And I particularly looked at opioid programs and policies around the world to see what countries were doing things better than we were. Because I had this unique experience of actually, living a life of an opioid addict, then going through the treatment programs and seeing how broken they were, to then being able to go to school and study it. After school, I actually became a consultant. I set up numerous sober living houses. I worked on developing some holistic treatment programs. And then I eventually went into the more formalized drug treatment world and was a director of one of the state's largest Medicaid youth facilities, and built quite a number of programs and worked on policies and agendas across Washington state. I had the privilege of working on trauma-informed care, integrating mental health, physical health, and behavioral health into treatment programs. I worked on the Washington State Medicaid transformation, where we integrated, again, that physical health and the mental health into care and our service delivery on how you actually treat people with substance use disorder, making sure it's not so focused just on drugs, but also looking at the underlying mental health that often goes with that. I actually passed policies and started the first sex trafficking program for youth in Washington state and collected some of the first real-time data for the state of Washington. And what I found was that 90% of young people who were sex trafficked were addicted to fentanyl. And whether that was on their own or purposefully addicted to fentanyl was something that I was starting to track. And the trend was very, very alarming. So as my experience living it, studying opioids, and then working in the treatment world, what I found over the last 12 to 14 years is a real shift. We went from prescription pills to heroin to then fentanyl, which has truly changed the game. It has created an epidemic on a national scale never seen before, as well on a local community level. We have seen more people die from fentanyl than ever before. Running treatment programs, it used to be that around 20% of young people were maybe doing opioids. Heroin was not as common as marijuana or alcohol. And what I started to see the last few years was that nearly 60% of young people coming into the treatment programs were abusing fentanyl. And probably nearly 80% of young people were unknowingly doing fentanyl, because that's one of the things that has changed is how fentanyl is distributed. It's put into multiple different substances. And so somebody today can be using maybe marijuana, or they think they're doing pills or Xanax, and they're actually doing fentanyl. I think one of the most important things when it comes to substance use disorder is addressing the stigma. I understand on a personal level what it feels like to be viewed as something, as someone would say, a dirty junkie. I remember the way people would look at me when I first got sober. I had track marks covering my neck. And I remember that feeling of shame and guilt and thinking I was never going to be okay. And I used to tell my mom for probably the first 2 years of my sobriety, I just don't think I'm ever going to be normal. I don't think anybody's ever going to take me serious again. And my mom really was the stigma breaker for me. She would tell me over and over again, Sarah, when you break a bone, it grows back stronger. You are never going to live in shame. You are not going to hide behind the stigma. You're going to share your story. You're going to share your strength. And you're going to let people know that they can and do recover. And that has really been my journey for the last 14 years. And if I can do anything, it's help break that stigma. Because I'm guessing most of you watching this would never imagine that I used to shoot heroin in my neck and was living in and out of halfway homes and pretty much on the streets towards the end of my addiction. But that was my reality. And I'm here to say that we do recover. We can recover, but part of how we have to do that is break the stigma on the macro level as well. I think there's been a large stigma when it comes to mental health just in general. You know, we've stayed quiet for a long time as a society, and now the time has come when we need to speak. Our young people are dying. We have more overdose deaths than ever before. Our kids have severe mental health problems. I think it's safe to say we can now all recognize that we have a problem. And so there's some things we need to do as a society and as a country to start to address that stigma and that shame that comes with substance use disorder. And some of that is to create this, is to end the disparity between physical health and behavioral health. I have to say that the National Institute of Health has published multiple studies that state that there is disparity when it comes to investment and funding. The United States pours trillions, billions and trillions of dollars into physical health research and funding, and a tiny fraction of that goes to substance use disorder and mental health. Another disparity is when it comes to wages between physical health care workers and those in the behavioral health field. On average in Washington state, a substance use disorder counselor makes roughly $26 an hour. When you compare that with a nurse, they make up to $77 an hour. So when it comes to incentivizing people to even come into the behavioral health field or become a substance use disorder counselor, the incentives are very small. Most people are actually still living in somewhat poverty that are actually working in this field. And then the third disparity is reimbursement rates. I recently went to an urgent care and I had a 15-minute check-in with an urgent care doctor and I was billed $300. That's $300 for 15 minutes. Now, when you compare that to the reimbursement rates that we used to get running a 24/7 residential inpatient care unit, we were paid $375 for one day for the full 24/7 hour care to treat people with a substance use disorder. 15 minutes, $300 versus 24/7 care for $375. It's absolutely nearly impossible to provide quality health care for people with fentanyl and opioid use disorders at these rates. So we've got to address these three areas of disparity: investment in spending, wages, and reimbursement rates. It took me about 2 years to feel quote unquote normal in my recovery. I was privileged to have a mom and family who were able to pay out of pocket for long-term care for myself. And I really believe that's why I'm alive. And yet the majority of people who are on Medicaid or other even private insurance, they have a hard time getting reimbursed for over 28 days of treatment. And truthfully, that's a joke. I mean, when you break your pinky bone, the smallest bone in your body, you have care for up to 6 weeks. And you're able to see your doctor, receive care, and that's the smallest bone in your body. And yet we think that just 28 days of care for somebody with a biopsycho and social disorder called addiction or substance use disorder, that 28 days is going to solve that problem. It's absolutely ridiculous. We need to have longer treatment stays. We need to have insurance reimburse. Honestly, I believe up to a year of different forms of treatment, including housing and aftercare support services, because you're dealing with all three aspects of health: the bio and physical, the social and emotional, and then the behavioral and mental health. And it takes time to heal. And that's where we need more investment to find actual credible treatment methodologies. And we need to know what really actually is going to help people recover and live in healthy, sustainable lives. 28 days is not long enough for treatment. We have to have longer treatment stays that include the physical, the mental health, and the social aspects of health. The project that I'm working on right now is actually one of the ones that I'm the most excited about. I helped pass legislation called Substitute House Bill 1929, which establishes the first post-inpatient behavioral health transitional living programs. And we're in the process of building these and are about to implement them in Washington State. And what it's going to consist of is 2 housing programs, up to 90 days of post-inpatient care treatment with wraparound services, as well as a individualized return to community plan, so that there will actually be a case manager working with young adults ages 18 to 26 who are at risk of becoming homeless, and making sure that they have all aspects of their life put back together before returning back to their community. It's one of the first programs of its kind in Washington State, and I believe it has the potential to be a national model. So part of the work that we're doing through House Bill 1929 is trying to create a more culturally and developmentally responsive system that integrates the behavioral health world as well as the homelessness world, in really strengthening and connecting these two systems that are often fragmented, and looking at how do we integrate these cares and services together. And that's why these housing programs are going to really help create a robust aftercare program and aftercare services that treats both those who are homeless as well as those who have behavioral health, which are oftentimes the same individuals. I'm also on the Spokane Fentanyl Roundtable with the Spokane Health District, and I'm the co-chair for the post-system care work. I also sit on the reimbursement work group, where we are starting to look at how to strengthen and change some of the reimbursements for Washington State to make sure that we can have longer aftercare services, make sure that transportation's included, and really understand how some of the most at-risk populations, such as those experiencing homelessness, have access to better services for their fentanyl or opioid use disorder. So today I'm a consultant with a company called North Star Advocates, which is a nonprofit that really is focused on ending homelessness for youth, young adults, and families.